Look at that. I'm
Hello.
starting. Hello, Dustin. This is a 62-year-old lady, no significant prior medical history. She has symptoms of upper abdominal discomfort since, I believe, August last year. But if you challenge that and if you ask her how she did as a young adult, teenager, then she's always probably been someone who's been more on the sensitive side of things. She's avoided certain foods. She's also avoided gluten. She's been scoped previously, Dr. Schaufelberger, and I think she described some gastric remnants of food, which we actually can also find today, right? I don't think I made a picture, sorry. Image, sorry. Yeah, but there's too much stuff in front, so, okay. I'll go back to the esophagus in a minute. Already had some findings there on first notice. So going into the antrum, this pylorus looks different from the one we previously saw. It's rather wide, so I easily pass without any restriction through. And now I'm going into the short bowel. Now, apparently she had a CT scan which found this, which was not seen on prior endoscopy. Let's go a little bit closer if we can advance down there. This is in the third part, so it's far down. I may not be able to advance there. So there's a diverticulum, right? And I think you all appreciate that. Maybe I can get some anti-film to have a quick look, but I mean, it's already very well visible. It's well accessible by the lumen. It's probably still easy to miss this because it's rather far down. So let's clean this a little bit here. So this is the only diverticulum. It's large, really. This is the only diverticulum that was described, right, on the CT scan?
Yes.
Sorry, this is a Pentax and I'm used to Olympus. Forgive my... Now we got it. Yeah, and there's the lumen going towards the right. Huh? And obviously the question is this responsible for your symptoms or is this an incidental finding? There's no obvious dilatation visible, neither on CT nor on endoscopy. I mean, it's rather wide, but it doesn't look crazy. But obviously she'll have food stasis there, right? No other diverticular, as I said. Rest of the small bowel looks normal. Probably I won't be able to go down there with the flip because it's rather far down.
I'm happy with pylorus.
Okay. But yeah, challenge is always nice. Okay, let's look at the hiatus because we haven't done that. She's not dysphagic. She does have, I believe, some mild reflux symptoms. The hiatus, yeah, that's at least a Hill grade 3, possibly 4, huh?
I'd give it a 4.
Yeah.
It was a couple centimeters of separation there, and yeah, certainly gaping.
And you can actually see already something that we should look again in anterograde fashion. Okay, so this is the hiaters. This is at around 40-41 centimeters. Going back, this is the Z line at around 38, 37. Looks smaller here, but I think we probably can induce a larger hernia. And you can also see, you cannot see this sometimes well endoscopically, but maybe the flip will pick it up. There is some stricture here. There's a small Schatzki, at least beginning of a Schatzki ring. So I would give this the diagnosis of a Schatzki ring with a relevant hiatal hernia. Again, the Hill grade 4 suggests functional significance, and the Schatzki does as well. She's not on a PPI, interestingly.
No.
It's rarely,
asymptomatic.
and she's rather asymptomatic for it, right? Rest of the esophagus looks fine. Okay.
All right, so have our flip here, Persian ready to go. I'll give it a initial pressure 0.
Oh, sorry.
That's fine. We can always voice compressor zeroed a couple times. All right. Okay. Here. Need a hand? Good.
So always try to get the tip of this angulating to the back of the pharynx, right? Not put it in like this. It's probably possible, but it's more elegant if you put it in like this, following, just like you would with a Bravo capsule.
Mm-hmm.
And Dustin and myself, we believe in blind placement. You can hear the patient coughing if it goes in the wrong way. And we are both comfortable with passing it down to the stomach. So I go in about 50 centimeters,
Yep.
and then we just inflate, and then we...
Yeah, I feel like very often I can actually feel it pop through the EGJ, and so that's where I know I'm in an appropriate place. But in the end, the positioning really is confirmed on the real-time display as you start to fill. Yeah, and this one with the hernia, I wonder if we can actually see that separation here. We'll keep an eye on that. All right, looks like it needs to come back a little bit. All right.
That was for a second.
Mm-hmm.
So you put it directly to 40.
Yeah, so I usually stop at the 40 ml fill. If it's too full, then it's a little bit hard to maneuver. Yeah, but even here you can actually see this very well here, the crural contraction and the EGJ. And so, yeah, already they're at like 2 to 3 centimeters of separation. So
Why don't you take the filter out for a second, Dustin, and
Oh, sure.
have a look. Filter set on standard average.
Is it standard or weighted?
Do the weighted. Filtering level medium. So we discussed this prior, and Dustin likes to turn the filters off because he feels that he sees the diaphragm and therefore the cruise better. Maybe a little bit, right? But we can still appreciate
Yeah,
it.
you still definitely can appreciate it here. Yeah, I do like the extra detail and the crispness, but yeah, here when it's still very apparent. Here we can start to do our filling at this point.
So Dustin also has the average, has the advantage, I would say, of using post-processing software. If you don't have that, and if you want to manually read the data, it's more easy to put in a filter because the values change a little less quickly. So from a practical standpoint, using a filter can be helpful if you don't use post-processing software. So it pulls actually a lot, and maybe this is something I didn't mention on the first patient, but if you have peristalsis, very often it pulls really strongly, so you have to tightly hold it in place where you want it.
Is the catheter now?
Say
How
what?
long?
Well, the catheter or the balloon itself, the catheter is long, but the balloon itself is
the
16
position
centimeters.
now.
So
Your
the,
catheter.
well, you can see it actually here, right? I mean, you see here very nicely the crural diaphragm down there. And normally we would want the EGJ to be lower, and Dustin, you tell me if you want me to retract it a little bit. But for the sake of measuring the hernia, and there's nice data actually from Dustin's group, right? Showing that it's a little bit better, even than HRM probably, than picking up hernias.
Yeah.
I like to see them both, but probably now we can pull it back a little bit to appreciate the tubular esophagus. Do you agree?
Yeah, I think at this point, I think one thing what's nice to demonstrate here too, though, is you can see that with that filling, the hiatal hernia sometimes will expand. I think, and sometimes, yeah, with that disruption of the phrenoesophageal ligaments, you can generate this out. Though I agree, I think once you've kind of identified the hiatal hernia, yeah, at this point it would be reasonable to pull it back a little bit, and we can even get a slightly better look at the EGJ, and maybe even to try to do a little more proximal distension in the body to pull out some of the contractility.
So I'm pulling it back. Again, this is quite strong resistance. You just need to get used to that. No harm in doing any damage with this catheter. It's very soft, even if it's filled. And our balloon pressures, you can see them up there. They're above approximately 35 to 45. That's still a very soft balloon, so you're not doing any damage.
Yep, and yeah, you can see now that we've actually have distended more of the esophageal body. Our nice secondary peristaltic, our repetitive antegrade contraction pattern is kicked in. And then, yeah, and even looking at these EGJ measurements here, we do try to focus on measurements at the peaks of opening. So at right here, when the diameter is 17, a DI of 4.8, and the pressure right around 45. And at the next one here, I can even pause it to pull that out. Oh, got it. Oh, darn.
And now it doesn't want to open anymore. This sometimes
Yeah,
happens.
of course.
You have to give it some time. Yeah,
Yeah. Oh.
that's not bad.
Yeah, so right here, yeah. So getting up to, yeah, at this point it's 14.2 with a DI of 3.8. I think if I run it a little bit longer there, we'd catch a point of
there we
even
go.
greater opening.
Perfect, perfect. That was a good one.
Yep. It's not that very responsive with my gloves on.
Yeah.
But even here, yeah. So nice normal EGJ opening values. Diameter here, 17.4, the sensibility index of 5.7, and the pressure here is a nice 42 millimeters mercury. So as we were talking about, kind of in that good range there, at least more than 30. And oftentimes you do see that pressure generated to open the EGJ when you have the push from the antegrade contractions.
And we have nice antegrade tubular activity, so we can already say, I would argue, that the esophageal body peristalsis is fine in this patient, which basically exclude a major motility disorder.
Yep, again, yeah, and just like the last one, yeah, the probability of a major motor disorder here is next to 0. So yeah, so from a ruling out major motility disorder standpoint, I would say we have succeeded in that endeavor. And again here, yeah, sometimes, yeah, fill up to the 70 ml fill arm, but sometimes show what you can see here where it looks like these contractions are weaker, though this is, again, where they often are not, and actually, you know, from a pressure generation standpoint, sometimes it actually can be even stronger contractions, even though the diameter changes aren't as profound. So yeah, so even kind of looking at kind of subtle pressure oscillation. But yeah, it's still some antegrade contractions and certainly EGJ diameter here. I mean, it does look like it's maybe hitting a little bit of a plateau right around 18 millimeters, and that probably is reflecting that subtle ring.
Yeah, let's see how it looks later. It's possible that we cause a little bit of bleeding there, meaning a little bit of a therapeutic effect. But we'll have to see. Again, please be reminded, this looks like an HRM, but it's not. It's diameter depicted, not pressures. I think that needs to be repeated because you tend to look at it like it's a pressure curve. It's not. It's diameters.
Yep. Yeah. And even sometimes when Dr. Pandolfino and I are talking about this, we still call this the high pressure zone. Though then we have to immediately correct ourselves because this actually is a low diameter zone that indicates the EGJ. So yeah, even after many, many flips, it's sometimes still hard to reverse your mind.
You want to do the 70?
Oh, I did 70. I'm coming down now. Yeah, I thought. Do you want to move on to pylorus?
Were you at 70? I thought you were at 60.
Oh, we were at 70. I came all the way down.
Okay.
Oh,
But let's go up one more time, and I put the scope in to show the image of the. Maybe we can see the Schatzki even well.
Okay, sure. Sorry. Thought we were going to move on to pylorus.
So if you have a good balloon filling, you can actually very nicely scope through the balloon, which is very elegant. You can see the opening rather nicely. You need it fully filled, otherwise it doesn't really work. And then you can advance the scope together and you can observe basically the EGJ. It's not opening up a lot right now. This is more contractile activity and not the ring that we saw. But you can delineate it. I think down there it's coming. So we'll go slowly through. Is it filled? It's not filled all the way, huh? Can you inflate it more to 70?
Oh, sure. I can go up to 70. Yeah, it's at 60 right now. Yeah, you see our hiatal hernia coming out again here.
There we go. This is how it looks like in an achalasia patient.
Yeah, and you can see that, yeah, actually at this point, I think, yeah, we move the scope, the distension. Sometimes you can actually elicit a little LES contraction, but it's just that reactive response to the...
And there you see very well already the ring. Can you see it?
Yeah.
Mm-hmm.
So this is nice. I think it increases the sensitivity of looking at Schatzki's. Because again, the sensitivity of endoscopy to rule out a stenosis is about 25 to 30%. It's low. Okay, but I'm fine with that. I don't catch the lower part very well from the angle, but that's fine. So we'll deflate it. I can already use the time to push it into the antrum. I'm not going to traverse the pylorus below 40 to avoid any theoretical impact on measurements. Deflating takes a little bit of time. If you have it fully inflated, it takes around 2 minutes to fully deflate. So you got to...
Yeah, it's 30 ml per second on the, or 30 ml per minute on the emptying rate. So Yeah. This emptying of the flip sometimes is can feel like an eternity, and maybe my least favorite part of the test, just because the filling is so exciting typically.
Yeah.
It's just the letdown of the excitement, you know.
That's right, yeah. All the adrenaline is gone.
Yes. Oh, nerd alert.
So maybe you can comment once again if you how do you pass the catheter through
Sure.
the panels?
So I like to do this in a kind of like in a Sullinger technique. So I have basically both in my same hand, the scope and the balloon. I like the balloon to be a little bit filled like it's now, so we can actually deflate it further. But I like to have it like this, and I want to be not fully at the tip, but also not too far back, because then it can kink.
All right, we're at 30 ml fill now. You want less?
Yeah, actually, let's start deflating further, and I'm advancing now both at the same time, and you can see that I'm easily passing into the second part. Now I maybe need to pull back the flip a little bit while holding the endoscope in place, right? So I'm now basically almost close to it, and then I go and I kind of try to push the tip around. Sometimes it doesn't work, I have to go back a little bit, push on the tip, and then advance to the side. If you have, this can often happen, right? That this gets kind of like stuck there before the parse 2. The autonym, it simply needs a little bit of time. Sometimes more, sometimes less balloon filling. And I like to use a forceps if that doesn't work.
I'll touch it, if not, you know.
Well, we can probably try that as well. Maybe you stop there, Justin. I think there's not much left in
No,
it
it's
anyways.
yeah, basically empty.
Basically empty. So she does have a little bit of a enlarged bulbus. Not that there's normal values for that, but that's my visual impression. Okay, now I'm reaching the second part. Again, I'm advancing both at the same time. Now is the time where I retract the scope a little bit, and I hope the flip stays in, while now going back in together with both, because the traction otherwise in the esophagus is too high, and I'll pull it out again. This looks like a rather large pull-out, I can say that. So maybe there is functional significance basically of the because this is a large bulbus, huh?
Is it a lot what?
Bulbus.
Okay.
But let's do the pylorus first, because that's what we came here for. That was our job, right?
All right, so I'll start to add some fluid again.
I get rid of most of the air.
Okay.
I don't get rid of the scope. We discussed this, I think, with the prior patient. You can see some duodenogastral reflux there. Did she have chemic gastritis on histology? Probably, huh?
Sorry.
Did she have a chemic, like a
Yes,
grade C
like
gastritis?
C gastritis, right.
Yeah, that could very well be that, and that she also feels that, right? I mean, also looks a little bit challenged, the mucosa.
Why do you say a large duodenal valve is associated with the diverticular or with this?
No, I'm just, I'm obviously now looking for something, right? We have the large diverticulum, she does have symptoms. The pylorus is rather wide, I would say probably wider than usual. So I'm wondering if and that's also the question of the CT. CT didn't show that, if there is a functional relevance of the diverticulum or not, which is hard to say, right?
It's hard to say.
But I would say that from having looked at many bulbuses, this is on the large side. I don't know what you guys think.
Actually,
Oh,
kind of
wonderful! Look, we have
Yeah.
the new application now, which is antroduodenal manometry.
antroduodenal panometry. Here it
Sorry,
comes.
yeah, panometry.
Yeah, so we're at the 50 ml fill volume now. You want me to go up?
Yes, please. Why do we want that? Because the bloom pressure is like 8. We're not going to do anything. But it's nice to look at the motility pattern, right? I mean, that's interesting. So even at 60, we are not really sure what we are doing. Please also note you have now 2 areas where you might think the pylorus is, and I'll leave that up to you where you think it is. We'll
Yeah.
discuss that now.
So I guess as I would look at this, I would say that no matter where you are, you're wide open. So
Okay, that's one way of putting it.
yeah, that's,
I like it.
Sorry, that's the simple esophagologist perspective here.
Oh, it's good. Yeah. Well, on the other hand, actually, it's showing you the pars 2 probably wrongly as the lowest part because this is the kinking of the catheter, and one reason for that is that we have not enough balloon filling. So please, let's go to 65.
All right, we're at 65.
Now, if you're very unsure of where you are, you can basically these rings are separated by 1 centimeter. These impedance rings, right? So what you can do is, if you really don't know what's going on, you go to the tip and you try to visualize where you are, and you count the rings. 1, 2, 3, 4, 5, 6, around 6. So actually, the pylorus is up here. It's not here. Very important, because if you would look at it, you might record these values. As Dustin was saying, probably doesn't make a difference because white is white. But I mean, let's try to be clear and specific here, and let's try to be Swiss here, and it's up here, right? So, but I totally agree to this assessment. We have a diameter of 21.2 or 21.7, whichever value you're taking, and a diameter of 18. Remember the last patient? Totally different story.
Yeah.
So I think there's not. I'm not super excited about the balloon pressure, so I would like to ask Dustin to fill this to 70. Taking out some of the air, or the CO2 that we are using here. Yeah, now the pylorus delineates a little bit better. Still here, 19.9, and maybe we write that down. 19.9 is our diameter. Distensibility is 11.8, and balloon pressure is 26. So clearly the pylorus is not a problem. So the answer is no, we're not going to do anything about the pylorus.
Don't go with the balloon into the diverticulum. We were hanging with bits.
Okay, I was just stopped in my enthusiasm by Dr. Schaufelberger, because I clearly would have now advanced the balloon, not into, but aside the diverticulum to see if there is any structural tightness. So maybe I do this next week without the cameras. But for now, we'll leave it as it is. So basically, we did find pathology where we didn't expect it, right, in the esophagus, because she was rather asymptomatic, rather open, hiatal hernia, some Schatzky. Let's look at that, by the way, because I mentioned we might have done a little bit of damage. She does have duodenal gastric reflux, so.
But it's not functional relevant, the shots.
Exactly. She's not symptomatic, so we're not going to treat it or do anything about it.
Symptomatic and not from the
Yeah. And I forgot our maximum diameter, but it was certainly not within the Schatzky range. But you can see there it was challenged, right?
Yep.
Yeah.
And that's it. And possibly we opened it a little bit. This happens if you do the maximum, and that's okay. I mean, she might have more. Maybe she has heartburn now because I mean, obviously the Schatzky is there to protect her esophagus, right? That's what nature does it. But I mean, we don't see anyone thinks we see any Barrett's. I don't see any indication of that. Maybe some subtle changes here, but I'd be okay, probably.
Yeah, I would leave that.
Yeah. Also, she's not. I mean, she's slender. She's non-smoker. She's female, so she doesn't fulfill the classic risk criteria for that. But again, she's dyspeptic, and I guess now the treatment could be: do you want to treat? Do you want to do something more to the diverticulum? You want to try a course of antibiotics? Possible SIBO. They did a lactulose test, which was negative, but I mean, this is a diverticulum, and it surely ferments in there, even if the test is negative. So this is one way to go about it. There is some gastric stasis, but it doesn't seem to be the pylorus. So either it's a feedback mechanism through the duodenum, through the diverticulum, or it's the body of the stomach. We don't know that. You could try Gaviscon to get rid of the bile which is in the stomach. That could be a trial. Would also help with the reflux. Yeah, I guess that would be a simple way to start trying to get her better.
Yep. And then, there was a question before about saving the Endo-FLIP data. With the flash drive in the machine here, there's just this icon that says archive data. And so very simply, that's pressed, and the data ends up on a flash drive. And in working with your local IT as far as patient compliance and places to store that. It's now in the file and can be used with the post-processing analytic software. Yeah, we have a.
But first you save every image that you want to.
And if you also, if you had any images that were saved, they also would have been uploaded to a flash drive plugged into that display.
And maybe a little practical tip. What we like to do is that we take the empty bag and we tape it to the sides. Also, if you do measurements, you treat and you do region measurements, and this is simply your bag where you put it in. There's no holder on the machine. Okay.
But then, what was the line that we saw the whole time there? That line that we
This
say
one?
is not the pillars, correct?
This is the kinking where it goes into the parse tube.
Okay, the blue screen.
It's a long catheter. It's not fully filled,
Okay.
right?
So that's why.
So this is the kinking, and so this is something in the esophagus you don't have that problem. There's no kinking unless you have a crazy achalasia, type 1, totally decompensated, and then actually you may also need some help with placing it right across the EGJ. But other than that, in the esophagus you don't have that issue.
All right.
Great, thank you.
Thank you.
Welcome.
Yeah.